So I think to take this conversation even to the next level, I want to introduce my colleague, Kai Ruggieri, for the next session. So Kai, turning it over to you.
So thank you very much, Kathy, and welcome everyone to this session. As Kathy said, my name is Kai Ruggieri. I'm an assistant professor in the Department of Health Policy and Management at Columbia University School of Public Health. I'll be moderating the session. In this session, we're going to examine. Sorry, could anyone hear me up to that point? You can hear me? Okay, sorry. I just got a message saying, great. So in this session, we're going to examine issues of confidence and trust in public health emergency preparedness response science among different demographic groups. Specifically, we're going to talk about how different demographies engage with and experience the science of public health emergency preparedness and response. And we're also going to can equally create challenges, not only for how, sorry.
Kai, I don't know if you can hear us, but we're having trouble with your audio.
Sorry, do you hear me okay now?
Yes.
It just told me that Zoom quit. I'm very sorry for that. I think to make up for time, I'll just try to skip ahead to getting to the panelists, and my apologies. So for our panel to discuss the topic that we've just presented, we have a panel representing a range of experiences and backgrounds, professional roles. We have individuals from government, from academia, industry, and from nonprofits. I'm going to invite each speaker to share their remarks. Each will have 5 minutes to speak, and then we will have Q&A at the end. If you'd like any more information about our panelists, there are links to the bios have been posted on the event webpage. And if you have any questions to ask, please put it in the Q&A window in Slido beneath the video player. So first, I'd like to invite Emily Brunson, Associate Professor at Texas State University and Principal Investigator of Communivax. Emily, you have 5 minutes.
Thank you. It's a pleasure to be with all of you today. So picking up on what the last panel was discussing, during emergencies like the current pandemic, public trust is an area of primary concern. Public confidence in medical countermeasures, public health emergency response, and the science behind these is absolutely necessary for the emergency to end or at least be mitigated. During the current pandemic, for example, public trust was and is needed for compliance with public health measures, including social distancing, mask wearing, and vaccination. For vaccination in particular, great efforts were made to ensure that the public understood that the vaccination was necessary and that the approved vaccines were effective and safe. The federal government, along with state and local governments, as well as public health departments at all levels, as well as various advertising and public interest groups, developed communication strategies that were meant to ensure public confidence in the COVID-19 vaccines. Despite this, vaccine uptake has been both challenging and less than ideal in many areas. So what was and is happening? Is it mis or disinformation? Is it a function of social media use? Is it a lack of trust in science? Yes, to all of these in different ways. This is a complicated situation, but in my minutes remaining today, I would like to highlight another cause for mistrust that is particularly prevalent in minority and marginalized populations, and that is also problematically overlooked when confidence and trust in public health emergency preparedness and response is considered, and that is trustworthiness of systems. Trust in both medical and public health systems and the government as a whole are foundational to trust in science, public health initiatives, and medical countermeasures. Without trust in the institutions, there's going to be mistrust in everything that comes out of them. Consider an example from our Communivax team in Prince George's County, Maryland. In this area, Black residents reported that their local and state public health departments had been missing in action for many years. While this was really an issue of funding for public health locally and at the state level, Local residents saw this as a reason for mistrust. As one person stated, why are you, speaking of the public health system and government writ large, so concerned with us now? Where were you when we needed help with type 2 diabetes, with heart disease, and access to care? Likewise, in Alabama, many Black community members referenced the Tuskegee syphilis study when discussing COVID-19 vaccination. They were using this as a metonym. It's been referenced in relation to other public health measures and medical interventions with Black communities in this area. But it was really being invoked then, and in this case with COVID-19 vaccination, as a shorthand for the longstanding unequal treatment of Black persons in health settings. The conclusion being drawn from this reference is that the existing health system cannot be trusted at face value. This distrust, in turn, allowed some individuals in this area to more readily accept narratives of carelessness. For example, that the Pfizer vaccines have been mishandled or unsafe. Incompetence, for example, the vaccine may give you COVID, and or malice. So the government is using vaccines to install a monitoring chip. Similar issues of trust in the system were prevalent in the Hispanic and Latino communities in Communivacs in California, Idaho, and Baltimore, Maryland. In this case, though, it was distrust of the system and particularly the government's purpose in mass vaccination efforts. Perceptions of what the government was trying to do or what it would enable kept many persons from receiving vaccines, even when they wanted to receive them. As a community health worker from California explained, they are afraid. Why? Because they say, I'm going to go, they're going to ask me for my information. They're not supposed to, none of that is needed. But nevertheless, the fear of being deported or just being questioned about their immigration status was holding them back. In these examples, trust in the medical and public health systems and the government as a whole was foundational to trust in science, public health initiatives, and medical countermeasures. As we move forward from this current moment, I suggest that developing and enhancing trust in these systems needs to be a central priority. Among other things, this will involve sustainably funding public health so that there isn't a boom of spending during an emergency and then a bust and nothing's available moving forward from that. It will also involve investing in community health and community outreach so that we can develop a robust community health system. If this is done, and that foundation of trust is in place, I believe that when the next public health emergency occurs, that the response and trust writ large, whether it's medical countermeasures, other types of interventions, if we're asking people to do things, communication efforts, that all of this will be smoother and that the messaging and the asks from public health will be better received among these populations. Thank you.
Thank you very much, Emily. I'd now like to turn it over to Venus Ginés, the president and founder of Dia de la Mujer Latina. Venus, you have 5 minutes.
Good morning, buenos dias. So I love what you said, and even in the previous program, I really enjoyed listening to the presenters. They were right on the issues that we're running into with health disparities. But you know, I want to go back a little bit to the beginning of COVID, the beginning of the pandemic. The United States was trying to navigate how to confront this disease, this virus. And while they were doing that, we had already trained over 3,000 promotoras and community health workers. Our training on dispelling myths about COVID-19 was approved by the state of Texas in February of 2020. So we were already aware that this was something that we needed to think about and be prepared for. And unfortunately, the public health system did what they always do. They pull in the people that look like them and think like them, and then they pull them together and say, okay, we've got to attack this, we've got to do this way, and we've got to pull these people together. And guess what? They forget to ask us. You know, so out went all of these infographics with featureless faces, and we're thinking, oh my God, that's a symbol for domestic violence in many of our Latin American countries. Don't use that. The little translation of some of the material was literal, and I'm talking literal and really poorly written. they forgot to ask us if we could review it to make sure before it goes to our community, we're really on the same page and giving the same message. But then there's another issue that I want to share with you, and we've heard it before. We just don't seem to be wanting to confront systemic racism. We've been talking about this for so many years. In fact, in 1997, I put together a presentation for the Intercultural Cancer Council, and it was on accessibility, accountability, and affordability, those three main barriers to our Latino community. And guess what? 25 years later, I pulled it up, and except for some numbers being changed, the system is still the same. And for people like us, the advocates, the people who, in my case, I'm a cancer survivor. So I have several communities that I work with, specifically, of course, our Latino community. But one of the things that frustrates me more is the fact that we can really help so much if the government would look at us as key opinion leaders and bring us to the table early on as they're preparing all of these strategic plans. And that's why many of us advocates feel that the public health system needs an overhaul. We need more community folks integrated, like our community health workers. And you see the slide here. This is an example of what we have done over the last 25 years, the impact we've made in all of these communities. And we were on top with COVID. We knew that the next thing that was going to happen is that people were not going to have access to all of this internet. So we set up 10 hotlines. And in those 10 hotlines, we were getting all kinds of calls related to domestic violence, to substance abuse, to all kinds of behavioral health issues, depression, anxiety, stress, teen suicide. And so we realized then that we had to put together a call center that would unite all of these calls, that we can actually be all on the same page as to how we were going to work on this. Guess what? We never got any funding from the federal government or the state government. We did it through no donations of folks in our community and the fact that I do a lot of translation. So what I'm saying here is, you know, if the problems are in the community, the solutions are with your community health worker. These are trusted members of the community, and as you can see, they've been trained on how to deal with behavioral health issues, disaster preparedness and recovery. They work with doctors, they work with patients, they work with researchers. We just developed a new training program entitled Clinical Trial Community Navigators. That's a community health worker who now is going to help the researcher develop a better strategy to recruit minorities into clinical trials. And now we're really looking at how we can bring some of these community health workers into the schools. My slogan from day one has been misinformation plus miscommunication plus misconceptions equals mistrust. And that's why we are starting a campaign, as many of us who are really frustrated with the fact that the status quo is still the same old. We are trying to now bring a message that no más, no more. We have had it with having to deal with these health disparities. You know, we're talking 25 years. I'm sure maybe many of the folks here could relate and say, yeah, I can hear you. You know, I've heard these same, the accessibility, affordability, accountability. I've heard those all for many years. We just don't seem to be getting any further ahead because we fail to confront the systemic racism that exists. The metrics that are used for funding from the government all the way down to the universities, they use metrics for people who are wanting to work with them in the community. And then they are not funded adequately and on a timely basis. And many of the community partners have said, you know, forget this. I can't deal with this anymore. I'm just going to go ahead and do what I can do in my own community. So, of course, you know, I am here to share with you that if we're really committed to trust and bringing trust back into public health, we need to be integrated into all of your strategic plans early on. And our community health workers and promotoras are, like I said, key opinion leaders. Don't give us $25 gift cards. You know, we don't need that. We need to be integrated. We need to roll up our sleeves and help you in developing some plans that will work in our communities. And I know my 5 minutes are up, but I just wanted to share with you that I'm very proud of our community health workers. They have done an incredible job. And even I'm in Houston, and they did a fantastic job during Hurricane Harvey. Again, without any funding, because we do what we have to do for our community, because we really, truly care about our community.
Very much, Venus. I'd now like to hand it over to Raymond Foxworth, who is the Vice President of the First Nations Development Institute. Raymond, you have 5 minutes. Thank you.
Good morning, good afternoon, everyone. I hope you can hear me okay. First, I want to thank the workshop organizers for inviting me to speak about my work and my organization's work as it relates to building trust in public health emergencies. And I want to first start with acknowledging that we actually know very little about Native American trust in public health institutions or about Native American beliefs during public health crises. In large part, this is because research in Native American communities remains underinvested in. So in this sense, we do need greater investment in research to better understand Native Americans and trust at all levels, including during public health emergencies. This is the first point I want to make. And also just related to that, this call for greater investment in research, I also want to note that this research really does need to be led by Native American organizations, including tribal nations and Native American researchers. Putting power in Native American organizations and tribes and with Native American scholars does help move beyond research practices that have at times spanned a spectrum from Native American invisibility to like predatory research that has been conducted in Native American communities. So we need more research and better research practice that really does respect tribal sovereignty, the diversity of tribal nations, cultures, and belief systems. I think Dr. Anderson on the earlier panel talked a lot about some of the vulnerabilities of Native communities during different public health crises. And we know that that history in the context of Native communities starts with European colonization, and that has perpetuated Native American vulnerability during various health crises and epidemics in the US where Native people have been vulnerable. That includes the influenza outbreak of 1918, where Native people were 4 times more likely to die from the flu than individuals living in urban areas. That includes the hantavirus in the Southwest, which was racialized and referred to as the Navajo flu because some of the first cases emerged on the Navajo reservation. So we know that Native communities, because of colonization, continue to be vulnerable during public health crises. And this includes crises to come, including the climate crisis, where we know Native communities are more vulnerable than other populations because of where they are, because of histories of removal and land theft. So I want to highlight those points and echo Dr. Anderson's earlier points. In addition to that, I just want to highlight a few things that we have learned during this global pandemic as it relates to trust and Native American communities. Some of this builds on the comments that Venus just talked about, and also, again, the comments made by Dr. Amber Anderson. To echo her point, culturally relevant public health information does matter, including ensuring that information is produced in Native languages and disseminated through Native media, also drawing on Native cultural values, worldviews, and belief systems. So really thinking about how to develop public health information, especially in times of crises, that is culturally and community specific, is really needed. The second thing I'll say is that Native American leadership and institutions matter during public health crises. In some of the work that we've done, Native Americans cite higher degrees of trust in terms of getting information about the COVID-19 vaccine. When it comes from other Native American leaders and institutions, this includes Native American doctors and nurses and other tribal health leaders, but it also includes folks like tribal leaders, tribal government officials, Native American political leaders like Native American state representatives, and individuals working at tribal health facilities and local communities. Right? This isn't to say that Native Americans don't express trust in the CDC or state health departments, but this is to say that Native Americans also ranked these community-specific leaders and organizations high in terms of trusting these individuals and institutions to receive public health information from. Building on Venus's point about community institutions, I just want to double down on that in the context of Native American communities. Our work at First Nations Development Institute has really focused on supporting local NGOs and businesses. And during the pandemic, these institutions were consequential in terms of response. These institutions helped build a local ecosystem of support that was critical for response during the COVID-19 pandemic. And we really need to think about these institutions and organizations that exist outside the boundaries of public health work during normal times, because during public health crises, they really are activated and mobilized to response for the benefit of Native communities. And the last point I'll make, similar to Venus's point, is about past experiences with racism and discrimination matter for shaping trust. In some of the survey data that we've collected at First Nations, there was a correlation between individuals who reported experiencing past discrimination in the healthcare system and vaccine hesitancy. And when I say past discrimination, I mean things like, a third of Native Americans believe they have not been offered the best available treatment by healthcare professionals. A quarter of respondents believe that they have not been referred to a specialist when needed, and 28% of respondents cited that they had been denied or delayed access to care that they needed. So we really need to focus on systemic improvements in our healthcare system to better understand trust between public health institutions and Native Americans, and understand that these everyday experiences that Native Americans have in terms of interacting with public health institutions really are consequential when we think about emergencies. So I will stop my comments there and look forward to any questions.
Thank you very much, Ray. I'd now like to turn it over to Lisa Letourneau, Senior Advisor at the Maine Department of Health and Human Services. Lisa, you have 5 minutes. Thank you.
Great, thanks so much. And likewise, thanks to conference organizers for the opportunity to share our perspective. So I am a physician by background, but serve as an advisor within the Department of Health and Human Services in Maine, which, as many of you might know, looks pretty different from several other states. We have a very largely rural population. We have a relatively quite a small centralized public health infrastructure, which really meant that we had to, by necessity, and I think luckily in the end by design, to reach out to community-based groups in a large way to address these issues of trust around COVID in a way that I hope can very much form a basis for our public health emergency response for other issues in the future as well. So very much building off the comments of the earlier speakers, the last two, Venus and Ray, we learned pretty early on that in order to build trust, well, and we learned it because we heard it directly from our community. So in Maine, we really have two pretty distinct groups that have really presented a healthy challenge for us in terms of building trust and interacting to create an effective emergency response for COVID. One is with racially and ethnically diverse communities, which are largely in our cities, and cities in quotes, in Maine, they're pretty small, but in our more urban areas. Maine is still, unfortunately, about 95% white, but we do have growing numbers of diverse communities in some of those more urban areas. And then we have a pretty different challenge in terms of white rural Mainers as well. So somewhat different challenges there. But early on, particularly in the pandemic, we heard particularly from our racially and ethnically diverse populations in the more urban areas that we weren't listening to them. And so through a series of listening sessions and focus groups, they very clearly told us that they needed more ownership of some of these issues. Venus, your comments, they forgot to ask us. We heard that very early on, and luckily I think we're able to respond in a way to direct resources and create structures to contract with community-based organizations and ethnically based community organizations to be partners in these efforts. And so we're able to contract in total, I believe it's about 35 community-based organizations. I remember it's a very small state, 1.3 million people in all, of which about 25 of those were ethnically based community organizations in those more urban areas, and then about 5 or so more statewide community agencies like community action groups and area agencies on aging. And so contracted with them over the course of the last 2 years, have contracted for just over $8 million to do the work, to really have ownership of some of these efforts, starting with social service support. So when we went out and talked about prevention and the importance of early testing and quarantine and isolation, not surprisingly, we heard from many of these groups, well, how are we supposed to do that when we have families with, 5 or 6 or 8 individuals, and they don't have more than one bathroom, and they don't have paid time off from work. And so set up a system of state-supported social supports. And these contracted organizations very much helped with that in terms of outreach, literally door to door in the community, many of them using community health workers, as Venus mentioned, to go out and do that work. And really based on that relationship that they had, right? They were literally of the community, working with the community, and were trusted messengers because they had that authenticity, the empathy for the people they were working with, and understood the language and effective ways of communication. So started with social supports, supporting more effective methods for quarantine and isolation, offering resources, hotel accommodations for those who didn't have space to quarantine or isolate, bringing appropriate foods, culturally appropriate foods, and then supporting subsequently testing through things like on-site testing, take-home kits, providing them, and then vaccination through things like pop-up clinics and mobile clinics. Through that, I think we were able, and we've seen in the statistics, very good results around the vaccination rates, specifically in ethnically and racially diverse populations. Less so, I would say, in the white rural communities where we don't necessarily have those same relationships, and they are starting to look for more friend groups. Like, who do folks listen to? I do this because I listen to my friends. So from there, really starting, we still have a lot of work to do there. Our rates, unfortunately, in those communities, not as good. If you could just bring up my little slide at the end to show for that white rural Mainer thing, really trying to figure out, well, who do they trust there? And this is just, I thought, an interesting example. The snowmobiling club. So in Maine, it's still snowmobiling season. Oh man, I hope this doesn't make me late for my COVID-19 appointment. Yes, that is a family of moose crossing the snowmobile trail back there. So I think I'm at time. I will wrap up, but again, appreciate the efforts of everybody to learn from each other, and I will pass it on.
Thank you very much, Lisa. I'd now like to turn it over to Ann Zink, the Chief Medical Officer for the state of Alaska. Ann, you have 5 minutes.
Great. Thank you so much. It's wonderful to be here with this panel. Thanks to everyone for organizing and some fantastic comments made earlier. I would echo many of the things that would be said previously, but I thought I might just share kind of a couple stories and trust. First of all, I'm the Chief Medical Officer for the state of Alaska. I joined this job about 6 months prior to the pandemic, and about 2 weeks in, I went to Kotzebue to talk about opioids. And there, the tribal leader said to me, "We will never trust you. You are never a part of this community. You're part of government." I still didn't really realize I was a part of government because I'd worked there for 2 weeks at that point. And so it was a good reminder to me. And I said, "What would it take to be trusted?" And they said, "You need to live in our community for at least 15 years. And I said, "That's going to take a long time to be able to do that in every community." But I think that was a really good opening to the job and what trust can take. And it doesn't just come from a series of Zoom calls and information meetings and pamphlets that are handed out. It comes from generations of working together and acknowledging uncertainty. So then the pandemic hit. And, as previously mentioned, Ray eloquently talked about the different Native communities and how they were decimated by the 1918 pandemic. We have 229 sovereign tribes in the state of Alaska. And the influence of the 1918 pandemic was powerful and palpable. And so we went to a couple of the communities early on when they had closed absolutely everything. Communities that had shut their doors to the 1918 pandemic actually stood there with gunpoint, kept their community, kept their language, kept their culture. And that history stayed strong, and that memory stayed strong, and definitely influenced the way that those communities, as well as the state, responded to this pandemic. And I'll never forget standing in the hospital it's this hospital that was built in the Bristol Bay area, and it was built out of the 1918 pandemic as the orphanage. And sitting there in that orphanage and hearing from Chief Thomas Tilden talk about how his grandmother went to the woods and stayed there for a year during the 1918 pandemic, only to come home to find essentially dogs and young kids alive. and most of the community had died during the pandemic. And he had said, I have learned from that lesson. My grandmother told me never to forget this. And now I am chief, and I will not forget this. And I will not let this pandemic decimate my community like it did before. And so I think just in that previous speaker acknowledging the past, but also looking towards the future, we had to have a two-eyed view on this pandemic. We had to both acknowledge that history. And I am incredibly grateful for the tribal leaders of the state and the Alaska Native people for helping me to see that past, as well as being able to move into that future. We had a lot of missteps. We had a lot of mistakes. We continue to do. And many of the themes that have come up on this conversation, we've tried to build in. We've tried to acknowledge those uncertainties and continue to build in those conversations. Our Healthy Alaskans 2020-2030 is built with tribal partners as well as state partners. We plan together, we execute together, we research together, we look through the papers together. I never like presenting without my tribal partners at my side, and having here without them, it makes me feel like I'm speaking only part of the truth. I always want their voice there as well. But it's hard to have all of those voices at the table. And so we started to try to find ways to make sure we had as many voices at the table as possible, including doing a weekly echo series where every week our team would present the information that we had with COVID and hear directly back from the public. We also found that there were different ways that we needed to communicate. I remember going up to Utqiagvik and sitting with a bunch of leaders, and they said, where are your men? We only trust the men in this community, and we trust the whaling captains. And you have 3 women who came up here. And I said, great, let's talk to the whaling captains. And so then we had a whole series of meetings led by the whaling captains where they talked about COVID-19 and how to mitigate COVID-19. And they could ask us any question they wanted, but then they shared it with the community because they were the trusted leaders within that community. Building from that, we stepped on each other's toes a lot with testing and with vaccination. We partnered with our tribes as well as our local community leaders to say, what does this look like in your community? We said our goal for vaccines was to be fast and fair, just to get vaccines out and make sure that communities really had the buy-in and were able to choose what they wanted to do and how they wanted to use it. So we saw huge efforts to do deep sea fishing vessel vaccination, because that is where they saw the biggest inequities and the highest outbreaks. We saw language learners being chosen to be the first ones to be vaccinated. So those people would continue to be able to carry on that language and move forward. And what equity looks like in Unalaska versus Utqiagvik versus Anchorage is incredibly different in this state. And so for me, in one spot to say this is the way it should look really looks very different. So really trying to rely on our partners. Alaska has a long history of being prepared, from earthquakes to mumps outbreaks to most recently avalanches crossing down some of Anchorage, finding ways to be able to partner together. Another big thing that we did was really relying on each other's previous strength. So thinking about moving forward, I think the things that I just wanted to acknowledge was that we really all need to find ways to speak in our lane, to let local leaders be that voice and to share information together, to acknowledge uncertainties as well as to acknowledge mistakes, and focus on common goals, as well as building voices in at the beginning and then throughout, as well as providing mechanisms for feedback. So thank you for the opportunity. I'm looking forward to the questions.
Thank you very much, Amy. I'd now like to hand it over to the last panelist, Oriel Richardson, who is the Vice President of Morgan Health at JP Morgan Chase. Oriel, you have 5 minutes. Thank you.
Good afternoon, everybody. Thank you to the National Academies and to my friend, Dr. Ruggieri, for their opportunity to join this important conversation. A little bit about my background and I think why I was added to this panel. I grew up in rural Louisiana, and I thought that I would travel and live my life on the East Coast, but I went back to Tulane University for grad school, and I found myself subjected to Hurricane Katrina and the aftermath there. And since then, I've studied law, done a good career in federal policy before moving over to the private sector earlier this year. But one of the things that my foundation in law does is it kind of has in my career served as a checkpoint for analysis, where we're looking for solutions, and a healthy dose of humility and skepticism for thinking that there is any one solution to most of the types of issues that we're talking about today. All of the panelists highlighted some of the, I call it the initial pebble in the pool, of how we got here, where there are communities across the country that have a healthy dose of mistrust or their own amount of skepticism with regard to engaging with the federal government or with partners who help to advance public health and emergency preparedness research and plans. So, this level of trust varies. It varies by rurality, urbanization. It varies by race, ethnicity, by gender, by religious beliefs, by education level, and then probably to some degree every other subgrouping of people across the country. And theoretically, we could say, well, for each group, here's why. But fundamentally, I just like to categorize it as all of the isms, the racisms, the sexisms. Those things tend to help to color the way in which you can come up with a federalized, a central national strategy to better communicate principles that should be standard by like the national standards, that they should be standardized by national standards, but they have to be tailored for topography, geography. They have to be tailored for the different things that different communities experience. And I would love to get more to questions, so I'm going to technically skip a lot of my remarks because I would be rehashing what so many of the other panelists have eloquently stated. But the biggest opportunity in my mind, following the height of COVID, because COVID still exists, it's transforming a bit. But one of the biggest opportunities is to figure out how to best preemptively provide some standards for lay groups. We talked a lot about community health workers. They're an underutilized resource, but they're also a profession. And so not to get too wonky or legal with it, but because they are a profession, it varies by state in terms of what their standards are, what their education levels have to be, what type of training they may have. And so there's an opportunity even to consider whether there is room or space to develop some sort of national core of community health workers for times of emergency preparedness, so that we're not in the midst of something like a COVID in the future and then trying to quickly deploy resources and deploy educational materials to both come to some general consensus of what we mean by public health. It's a beautiful term that we're all in love with, but I think, in the United States, we have public health, we have health care, we have health and wellness, and it's really thinking about ways of co-opting all of those different tentacles and saying public health is really all of those things in a sense, and it's the core and foundation of what makes us better as a nation. And so I think the biggest theme I would say is not waiting until calamity is upon us to build that core set of standards and principles, to build the kind of universe of people who can go out and be deployed into communities to convey information. And I'm very, in some sense, practical and also a fan of Hollywood, for better or worse. It's generational. But one of the things that I do remember from the 90s was the campaign of one major media company called The More You Know. I also remember after school specials and after school campaigns where you would think you're going to watch one thing, or they would preempt Oprah for 30 minutes, and it would be something that educated a certain demographic about an issue, a social issue of the time. There's a need, I think, when we consider all of the things that face human civilization, climate crisis, different emergence of diseases, all of those sorts of things, to figure out how are we going to go back and re-educate folks where the public health system or the public education system might have not put us all on the same page. So, there are a lot of people who do that work, but I think really coming to consensus and having some resources trickle from the federal government with some standards for acting locally would be a great way to move forward. I look forward to your questions.
Thank you very much, Roya. I'm just going to do a quick reflection. Just as a note, I won't have camera on because for those who were here at the start of the session, you saw that I crashed. So I'm keeping the camera off, hoping the crash doesn't happen again. I was asked to share a few quick reflections on what was said, and we don't have a lot of time for questions, so I'll move very quickly. I just noticed one thing that almost all of the speakers mentioned was talking about system in the US in terms of the public health system. But almost anyone who works in public health or goes to a public health conference one time will hear, we don't have a system. We have thousands upon thousands of overlapping but indirect and non-central groups of systems that have a lot of overlap, but also a lot of gaps. And I think what came up a lot is that we saw massively, COVID was basically low tide in identifying what the gaps were, and we're seeing what the implications of those gaps have been. So I thought with just the little time we have left, if anyone felt they had any reflections or thoughts they want to share on specifically how addressing diversity across the country in these gaps could be addressed for the next time, or how admitting where mistakes have been made, if we address those, it can actually improve for the next time and make things better. So I just want to invite any of the panelists that would like to have a moment to reflect on the system writ large as we just have a minute or two left.
This is Venus. I'd like to share with you, just so we can see how prepared we already are. On April 8th, we're going to have a conference of community health workers, and the title of our conference is Preparing for COVID Aftershocks. And the reason we call it Aftershocks is because we have to discuss the variants, we have to discuss the mental health issues, we have to discuss the rising numbers of people with cancer because they weren't able to detect early. There's a lot of other issues that are arising out of this, and we call them aftershocks. And if we're already thinking of that, I hope that the folks in public health system are also thinking about ahead, how can they prevent the chaotic, discombobulated miscommunication and misinformation that was coming.
Just building on Venus's comments, I think that while everyone who's familiar with public health and public health practitioners in particular, you realize that there are multiple systems. This is not the perspective that the public has. They think about this writ large. And so I think it's, figuring out what those gaps are and addressing them. So once again, we need better funding for public health so that it's sustainable even when there's not an emergency. And then going back to the comments of many people, it's investing in community health, like Venus was talking about. It's having people who are really engaged with specifically minority communities across the US who are going to be able to lift up the public health efforts as well and bridge those communities as they need to be bridged. And that needs to be done all the time, not just during emergencies.
I guess I would just add, in building systems that really serve people instead of just people serving systems, it's really hard to know right now for treatments what the racial inequity looks like in that distribution, because we have no way to be able to see that data. So it's hard to change that which you cannot measure. And so I do also think that if the data that's coming out is uneven, if it's mistrusted, I think that there are a lot of systems that we could put in place now to make it easier on the workforces to get information out to, Venus and her community health workers to have the information at their fingertips that's actionable without having it stuck within all these layers of systems. And so I really think we need to invest in not only the personnel and the infrastructure, but the IT infrastructure to make this go more smoothly. And I think sometimes that gets lost in this communication because if we don't have trustworthy data, then what we're sharing is not trustworthy and it's hard to action upon.
Thank you very much. We have a brief moment left. Did any of the other panelists have an additional comment they'd like to share, whether related to the systems point or generally? We have just a moment.
I'd just like to add, it's always very important to think probably in the way that Venus thinks with her organization, but we have to talk to the people that we're talking about, and we have to get their input and their inclusion. I think, Ray would probably agree with this. We have to let them tell us what they need and try our best to use our influence to triage resources, develop collaborations and partnerships to make sure that it's actualized, but certainly not putting upon those who have been historically marginalized, I think is one of the most important points here.
Thank you. Thank you very much for that. I think that's a perfect point to close on. And also just to say that many of the topics that have been discussed here in this session really connect to later sessions and later panels that are going to be coming up, particularly those on infrastructure needs and building an enduring public health system that really does engender trust. So just want to encourage others to participate in those sessions as well. So just thank you again to our panel. Thank you for the remarks and thank you for the engagement. We understand there's been a lot of comments in the discussion.